healthcare. If you have any questions during the presentations, I'm not able to see it. My second screen gave up, so I'm only working on one. So please, I don't mind if you interrupt me or save it to the end. So let's see. Yeah, it's not working. Oh yeah, I think, yeah. For today, the learning objectives are to provide an overview of the relationship between food insecurity and child health outcomes, to discuss the contribution of food insecurity to child health disparities, and to highlight financial interventions to address food insecurity in child health care. So food insecurity is defined as the unreliable access to sufficient quantities of affordable, nutritious food. Food insecurity is a serious public health concern in Canada. So the following 5 slides with the graphs and the table are taken from PROOF. PROOF is an interdisciplinary research program led by Valerie Tarasuk. You see the website in the lower corner, and its goal is to create effective policy approaches to reduce food insecurity. They also measure food insecurity with the Canadian Income Survey, and this is data from the latest report. So from 2021, as you can see, the prevalence of food insecurity in Ontario was over 16%. This is, however, different for families with children. That rate goes up. When you have children, you have a higher risk of living in a food insecure household. And currently, Canada-wide, 1 in 5 children lives in a food insecure household. Who are those families who are more vulnerable to household food insecurities? So if you follow the figure, so if you have a couple with children, the third row, it's about 15% prevalence of food insecurity. But if your household is led by a single parent and a female, that goes up to 38%. And the male, a lone parent, it's about 20%. If we look at the percentage of individuals living in food insecure households by racial, cultural identity, and indigenous status, you see a higher food insecurity in Black racial identity, in Arab and West Asian, about 27%, and the highest percentage, I think we all know, in indigenous families. I'd like to compare this data from Canada with the recent report came out in the United States by the Centers of Disease and Control. The measure of food insecurity a little bit different, so the absolute numbers are not comparable. But what I found interesting is that they also looked at families with children with disabilities, and disabilities was defined quite broadly with any disability in vision, seeing, walking, hearing, or mental health. But the results were shocking to me that if children have a disability, they have a way higher percentage of living in a food insecure household than without a disability, 90 versus almost 10%, as you can see here in the green bars. So now I'd like to switch the topic a little bit to discuss food insecurity in child health. You've seen I put a picture of the hunger vital signs. In America and United States, doctors screen a lot for food insecurity in their practice with 2 questions. That's what they call the vital signs. I will not discuss screening here, but that can be an interesting topic for debate later in discussion, but I will move over to direct health outcomes. So the first association with food insecurity, what comes in mind is with malnutrition. However, when we look in high-income countries, there's not a direct association with food insecurity and undernutrition. That association is more seen with overnutrition, both overweight and obesity. This data comes from a recent systematic review published in 2021. They included 23 studies, 19 cross-sectional and 4 prospective cohort studies. And both the prospective and large cross-sectional cohort demonstrated that association with food insecurity and overnutrition in high-income countries. If you look a little bit more in detail to the nutrition status, Valerie Tarasuk investigated breastfeeding and food insecurity, and she did that with the Canada Child Health Survey, and from a period from 2005 to 2015, over 10,000 women were included, and they filled in questions about breastfeeding and also about food insecurity. And they found that women with food insecurity were not less likely to initiate breastfeeding or provide vitamin D supplementation. However, half of the food insecure women ceased exclusive breastfeeding early by 2 months, and most women with food security persisted exclusive breastfeeding for 4 months. So there is a difference here, and we call this the breastfeeding paradox. So the breastfeeding goes down when the household food insecurity goes up. A rather simplistic picture, but I think you get the message. What about specific dietary intake and food insecurity? There's strong data that children younger, from 1 to 5 years old, have food insecurity has a consistent and dose-responsive relationship with lower vegetable intake. And a little bit older children, from 6 to 11 years, there's a strong, consistent evidence of higher added sugar. And this data comes, I think, from the Heinz study. Allergies, as you know, we see lots of children with allergies nowadays. And when you have a food allergy, this often necessitates dietary elimination of certain foods and allergens, and which may be costly for families. And this study force plot shows compares 325 food allergic children versus 325 non-food allergic children in the range from 1 to 17 years in the United States. And you can see if children experience a milk, egg, and an egg allergy, they have a higher odds of living in a food insecure household. And below, I also found it interesting, the asthma relation. With the asthma, you have also a higher risk of living in a food insecure household. What about celiac disease? Also requires a more restricted diet. And what I found interesting is that these gluten-free foods are a lot more, 242% in one study, more expensive. So not all households can adhere to that. And this study also found that, therefore, children with celiac disease have a lower macro and micronutrient intake. So this is concerning too. I think as a pediatrician, my most concerns for food insecurity is the effects on mental health. This is a recent systematic review who included 108 studies. They were only from the United States. All studies were observational studies with medium or high risk of bias. But there was, in all these studies, it was clear that food insecurity was associated with depression, anxiety in parents themselves, but also with depression, externalizing, internalizing problems, including hyperactivity in children and youth, which is very concerning. This is a hypothetical model. On the left, we have food insecurity and how it relates to health outcomes. And I discussed the nutrition consequences of food insecurity, the poor diet quality, but also the psychological, the increased parental distress and depression. And the last box, the competing demands, I did not discuss yet, but I think everybody can understand that when you're food insecure, you probably have other expenses you need to pay, and this can also lead to a decreased therapy adherence. And in the right upper corner, you see the child health outcomes we discussed: mental health, malnutrition, depression, anxiety. And in the lower corner, you can imagine that it can have a negative effect on almost any chronic child health disease, food insecurity. So what about healthcare use and food insecurity? We have data from the United States. In the US, children in food insecure households have a 2 to 3 times higher probability of delayed or foregone healthcare, and they have an almost 25 or 26% risk of increased emergency room visits. What about Canada? There's not much data about food insecurity in children and hospital visits in Canada. We were lucky to do one study, and then for those of you who attended my health equity rounds last year, sorry, there will a little bit of duplication of the data. Um, so most of you are aware we did a study in sick kids examining food insecurity, and it happened to be during the first wave of the COVID pandemic. So it had to be all virtual. Our research assistant, Nusrat Savar, she called about 850 people from home. More than half actually filled in the surveys, and about 45% filled in the specific survey about food insecurity. And we used the household food security survey model that is used in the United States data, but also in the Canadian community survey. So this is that module. It consists about 18 questions, 10 for adults and 8 for children. And we determined if children were food secure, that none of the items were endorsed for both adults and children. Marginal food insecurity was determined if there was one question affirmed, moderate when people have compromised in the diet quality or food consumes, 2 to 5 for the adults or 2 to 4 for children, and severe food security was defined as 6 or more. And this is also the scoring method, what is done in proof. In addition to household food insecurity, we examined hospital-based food insecurity. We defined it as the inability of caregivers to afford adequate amounts of nutritious food during their child's hospitalization. These questions are, and I will read them. We could not afford to eat balanced meals during my child's hospital admission. The second, did you or other adults in your household ever cut the size of your meals or skip meals during the hospital admission because there wasn't enough money for food? And the third, during the hospital admission, were you ever hungry but didn't you eat because there wasn't enough money for food? So these were our data. And as you can see, the red circle depicts 34% of adults living in food insecure households. 90, almost 20% of the children lived in households who were food insecure, and about 38% of the caregivers had some level of hospital-based food insecurity. We also ask caregivers themselves if they have any other feedback about their food situation during your child's hospital admission. I will read 3 quotes. For those of you that were there last year, I have many more, but I want to move on to intervention, so I will just read 3, which I still found very impressive. The food in the hospital is too expensive. To eat even 2 meals a day will cost you about $30. If you're here for a week, that's over $200. It makes it hard. I went without food during the hospital admission because I otherwise wouldn't have had the money to get my car out of the parking lot when my son would be discharged. The stress of having a child admitted in the hospital is enough on top of worrying about getting yourself meals throughout the day while trying to care for your child, especially being one parent for the child during a pandemic. So, and to put a bit more quantitative results to the stress, we actually measured parent distress with the distress thermometer of parents of a chronically ill child. It's very simple. They have to indicate how much stress they experience or distress they've experienced in the last week. And the rate 1 is no stress and 10 is the highest form of stress. And we found that, not surprisingly, that even when we adjust for things like single parent household income, employment status, caregiver's own health, the month of admission and the child's age, even when we adjusted for all these factors, hospital-based and household food insecurity was associated with increased stress. So if any of these 3 hospital-based questions was answered with a yes, the distress score did increase with almost a half point. I'd like to show you also some details about the income of families who were who said they were food insecure compared to the food secure families. You see them in the blue, and I highlighted the red because actually we found that more than approximately 20% of food insecure caregivers were in the higher or income brackets. This led us to think that maybe caregivers experience financial costs because of a chronically ill child, and food costs, as we all know, they may be variable, and families may cut down on their own food to afford things like transport to the hospital, parking, and other out-of-pocket medical expenses. This made us think because income is strongly correlated with food insecurity. Um, However, when we looked a little bit in the literature, we also noticed that about a quarter of food bank recipients failed to file tax returns. And as you know, for families with children, Canada Child Benefit could be a way to increase the income in families. And when we look at Prosper Canada's report, Prosper Canada is a volunteer organization that has as goal to empower families financially, all Canadians. And their reports, they estimate that more than 1 billion per year in benefits go unclaimed. So this led us to, oh yeah, here is the slide that shows us how much money actually families could get when they, for Canada Child Benefit, 6,400 for children under the age of 6 and 5,400 from children from 6 to 17, but they need to have a social insurance number and file their income taxes to be eligible to receive it. So we thought, oh, this could be a way to improve income and is to help families accessing all their benefits. So we designed the Tax for You a pilot study. And the goal was to offer free tax service to families with a child admitted to sick kids. Again, the general pediatric ward. We were in the middle of the second wave or the third wave of COVID. So again, we had this intervention done all virtually. So we use an existing tax support program. It's called the Community Volunteer Income Tax Program, or short, the CVITP. This is designed by the CRA and often used in community locations. They have a pretty strict inclusion criteria. For 4 persons, they can't have an income more than 50,000, and also exclusion criteria. They couldn't be self-employed families. They couldn't have business or rental income or own a foreign property, and bankrupt individuals were also excluded. So again, our research assistant called many families. They sent them a recruitment questionnaire if they were interested to see if they met these criteria for the CVIT program. And unfortunately, we found only that a little bit than 30% were eligible to get the free tax services, and more than 70% they were not eligible to get these free tax services. Exclusion reasons was a majority, 58%, the CVITP program. Some of them already filed the taxes when we called them back. And like I said, we had to do everything virtual, and some parents failed to sign the consent form virtually. So 17% were excluded for that reason. If you look in more detail to the CVITP exclusion criteria, is that 40% it was actually income related. If caregivers earned too much, and a large part, 36% were self-employed. And mind you, as a reminder, Uber driver or Uber Eats or anything in the gig economy counts you as a self-employed. So that puts a lot of people out of the eligibility for the free tax services, even if their income was low. And about 20% owned rental income or foreign property. So these are the demographics, and you can see the first column were the eligible participants, and the second column the not eligible, and the third is the complete population. In the eligible group, there's more than 70% is a single parent household. You see there's more than 74% of these parents have trouble making ends meet, and above 60% experience some kind of food insecurity. In the not eligible group, actually, I was surprised. There's still about 46% saying they have difficulty making ends meet, and more than 30% saying some difficulties with food insecurity. And we look down to the last three rows. We also asked caregivers, did they file their taxes? And to me, this is quite low. We were the year 2020, so the 2 years before, not everybody, actually the majority, said they filed their taxes. So just to be honest, there were like some clarification. We asked one caregiver online on an online survey. So sometimes what could have happened that they're not aware if the partner filed taxes. So I'm not really sure if this is true, but we found this data quite interesting. So some experiences of the study participants. We didn't collect qualitative data, but this is some things participants said to us. This service for me is like winning a lottery, and I'm so thankful to all of you for doing this great project for the families who really need it. But also some upsetness. It was a randomized controlled trial, and why I have not been selected for this tax service, and why you're not offering this service to all families who are in need. And some of the tax volunteers who we used for this project said, oh, she was crying with tears as she didn't expect getting that much money from the government on a monthly basis after I did her income tax. As I said, the whole thing had to be virtual. We had trained tax volunteers and the CVITT program, but they had quite difficulties. A lot of time was spent contacting families over the phone, arranging appointments, and some clients had poor skills in organizing all their paperwork. And sometimes when they called them, the one caregiver said, oh no, my husband actually already arranged the tax filing, so it was not needed anymore. And the problem is the Uber driver that some people also didn't recognize this as self-employment by themselves. So when it was when they showed up for the tax appointment, this was something some of the tax volunteers discovered, and she helped them, but it was actually not approved of. Okay, so our study conclusion was that our Tax for You study was able to reach vulnerable families that experience poverty or food insecurity, but the CVITP program was not the right program for families in our hospital. So what's next? I think around that time, I read a very interesting commentary about medical financial partnerships in the New England Journal of Medicine. And they define medical financial partnership as novel collaborations between healthcare providers and financial service organizations. And they proposed in this commentary that maybe healthcare systems can collaborate and have an opportunity to address financial strain and stress and ultimately improve health by implementing these medical financial partnerships. So you have three different types of medical financial partnerships. You have the third is an offsite. You refer as an healthcare institute to a financial partner, community center. The second one is you only offered a specific program, like we did with the Tax for You study. Or, and this one model gets my interest now, is the on-site full scope financial services. This is actually a financial coach who helps, who is present in a clinic space and who helps to address a wide range of financial problems. For example, basic financial literacy training, budgeting, savings, free tax, but offers longitudinal follow-up. These are examples. Sorry for the busy slide. Please don't read it, but the authors provided an overview. And the first are three institutions in the United States: the Financial Fitness Clinic, Financial Futures for Family, Street Cred. They're in Boston, Johns Hopkins in San Francisco, and they're employed by a mix of volunteers and tax experts or financial experts. And the last row is one actually in St. Mike's Hospital in Canada. It only serves adults, but they also provide some kind of financial literacy and longitudinal follow-up, and is supported by the Ontario Ministry of Health and Long-Term Care. So this made me think, would it be possible in sick kids to have this more full scope medical financial partnership? But I learned my lesson and I thought, let's first ask caregivers themselves if this is something they would be interesting to use. So I had a great social pediatric research student, Ajanta is her name, and she helped me with a qualitative research project to gain a better understanding of financial needs and supports for caregivers with their child admitted to sick kids. There were semi-structured interviews we did with 15 caregivers. They all had a child admitted to the general pediatric ward. We again used some purposeful sampling. We sent them a screening questionnaire ahead, and we audio recorded the interviews and transcribed. So these are some of the characteristics of the 15 caregivers. So we had a broad age range of the caregivers themselves, 11 identified as being women. We had a diverse ethnicity, as you can see. We used for 4 families interpretation services. The families had children in different age ranges. We, like I said, purposely tried to look for diverse families. They had children had a different number of hospital admission with more than 5 or only 1 or 2 a year. We asked about trouble making ends meet and food insecurity. People and caregivers were also able to decline these questions. So this is the people who really said they suffered. 11 children had an underlying chronic condition, and these were the incomes you can see below. So I can't, we are in the middle of analyzing this data, so I can't read you all the quotes and all the teams, but this is how far we got. So on the left, this is some kind of model, so not a SEM model, but this is my own mind map, I think you can call it, with the teams we found. So on the left is the caregiver who has, of course, some experiences with their child being hospitalized, but also the tension with their employment because their child's hospital admission. And then the interview was, we asked a lot of questions about financial stress. And the themes we have identified so far is that the caregivers experience acute, more admission-related financial stress, like food, parking, transport. Caregivers certainly elaborated also on the ongoing cost, the food, the mortgage, the transport, and the out-of-pocket medical costs they have to buy, and the pandemic-related costs for the high inflation we experience nowadays. We also ask caregivers about support. So on the left is the government support and the hospital support. Almost all caregivers we interviewed, they did file their taxes, but they used someone to help them, either accountant or, yeah, most of them it was actually paid. And they all said there was a lack of information about benefits. And if they found a benefit, they found it very complex to apply for it. The long wait times to get the benefits, and then when you get it, the insufficient amount to cover all the costs, and a big theme was also the income cutoffs, because a lot of these benefits were people entitled of, they have income cutoffs, and often middle income families who have a sick child, they don't qualify for anything. We also asked families if they received some hospital financial support, and most parents weren't aware. Some met with the social work, but infrequent, and people weren't really sure what kind of financial support was then available. And as we asked them, and that's the last square in the bottom, or what we could design, or what kind of intervention they would like to see in a hospital to help them with their finances. Most of them, they said they would love some assistance with their acute costs. A lot of them, they would appreciate some more financial information. What kind of benefits are there? What are they eligible for? Definitely assistance with documentation. And some said they would use a financial center with ongoing support. So here are some of the quotes we collected so far. It is very draining to have a child hospitalized. It takes away from money that is otherwise marked for rent and for groceries and utilities and gas and so on. So this is a second quote is related to employment. And I know at some point, I know I have to go back to work, but currently, based on her appointments, and she has multiple appointments every month, we have to go like 3-4 times. So it's like back to back. So I can't go back to work and then ask them for a leave, right? This is about accessing benefits. I felt like there was some stuff that I could qualify for that I don't know about, but no one is telling me. And the last quote is about the bureaucracy. I would like to start by saying that every single special needs parent that I know, this is their first and foremost complaint. The bureaucracy, the paperwork, having to write the same thing over and over and over again for support. So next steps, our results demonstrated this lack of awareness of financial support and amongst caregivers and the challenging of accessing benefits. The majority, they found some way of accessing taxes and benefits, either through social media or to word of mouth. Um, but I must say, some of the caregivers, they also said, oh, I would not do any financial service in a hospital. They were worried that there wouldn't be ongoing financial support because if your child is not admitted or has a hospital appointment, could you still use the service? And some parents also highlighted, I just want the hospital to give good medical care and I don't need any financial support. Um, and what I found interesting is that most people, they lacked awareness of all these benefits and would welcome more support accessing benefits. So in Insecurity, we've now created a medical financial partnership working group. I have many collaborators, as you can see, in both thickets, but also in the community with Prosper Canada, Allison, West Neighborhood House, who already provide some of these financial services in the Toronto East General Hospital. Oh, sorry. Even some economists at Carleton University. So to be continued. A lot of people have asked, well, what about the hospital-based food insecurity? Yeah, what are you doing for that? And as most of you, I think you're aware, is that SICKIS has this model of family-centered care, where the child is in the middle and the family is essential almost as the child. We as providers ask families to stay with their child during hospital admission. As you know, families are not offered any food while their child is admitted. Their child gets food, but families not. After the publication of our first results, about 38% of caregivers experience a hospital-based food insecurity. We developed a working group, a Food for Families working group, and you can see it has broad representation about unfortunately along the whole hospital, with Tracy from the kitchen, Francine, patient representative, David from social work. I won't mention them all, you can read, but I really like it. And over the past short year, we have been meeting and we have created 2 possible interventions to address it, and have been given some internal funding to try those. The first is giving meal cards to parents, just a physical card that they can spend at the terrace cafe or even the meal train. We unfortunately have not funding for all caregivers to get such a card. So there will be some screening. We need to screen families if they have difficulties affording food in the hospitals. And the second pilot will be a meal card. So this is literally a mobile card where we can have some caregiver supplies, maybe books, but also healthy snacks like a bagel. And then everybody can access this mobile support card and no questions have to be asked. So I find it very interesting. We'll evaluate, of course, we ask caregivers themselves what they appreciate, and then hopefully we'll also have a better idea about the costs so that we can extend these interventions in the whole hospital and not only on the general pediatric ward. So at last, for me, that hospital food insecurity is very much related to equity in the healthcare and quality of healthcare. And I think that for me, it means that, all people, regardless of their gender, race, ethnicity, geographic location, or socioeconomic status, receive the good quality healthcare they need. And with a group, we were wondering if parents suffer from hospital-based food insecurity, would the quality of healthcare be the same? We designed a new study. We're going to investigate healthcare inequities and child and family-centered care and pediatric hospital care, not only in sick kids, but also in McMaster and CHIO. It will be a mixed method study with include surveys and interviews. And we've been awarded BSI funding. And this is the idea that now healthcare inequities can be maybe related to hospital-based food insecurity, financial logistic barriers, language barriers, and the experience of marginalization and discrimination. And this could be possible related to child and family-centered care. We don't know. We're going to examine. And if that quality of child and family-centered care is less, will it also relate to 7-day readmission or length of stay? So I don't know. We hope to start this study hopefully next month, and I'll keep you posted. So my conclusions for the presentations, household food insecurity is highly prevalent in children in Canada. Food insecurity is strongly associated with negative child outcomes and child disparities. The community volunteer income tax program did not meet the needs of our families and sick kids, and maybe a full scope medical financial partnership could be beneficial to improve financial stress in our population. Thank you all for attention. I couldn't resist your health equity round, so I have one quote that inspires me a lot. Every disease has two causes, one pathophysiological and one political, quoted by Rudolf Virchow. And I will read Valerie Terasuk's quote on food insecurity in Canada. Food insecurity is not the result of cracks in our system, but the design of our income supports and the decision to not protect households from poverty and food insecurity. So with this quote, I'd like to end and will thank all my collaborators here in Sick Kids, McMaster, CHIO, University of Toronto, and Prosper Canada, and of course the community. Thank you so much for your attention, and I'm open to any questions.
Thank you so much, Meta. That was a great presentation, and I had seen a similar presentation that you had made over a year ago for the Leong Center. So it was, really great to see, all of the progress that's been made since then, the new study that you're going to launch, the potential meal subsidies and how that will play out, and of course the medical financial partnerships model that's being pursued. So thank you so much for sharing that. And we will open the floor now to questions. So if you have a question, if you could just, raise your hand and I'll and unmute your mic. Any questions for Meta? Okay, Harpreet.
Yes, hello. Thank you so much, Meta, for that very, very informative presentation. And I think for those who may have attended past presentations, whether it was health equity rounds or at the Leong Center, it's definitely amazing to see the progress and the future work, which is really, really exciting. It'll be interesting to see those connections to child and family-centered care. I guess one question that I'll ask is, and this is a question that I think we get when we're coordinating health equity rounds and identifying presentations and who to invite to be able to speak to those who attend, is often we get, especially from our clinical teams, an interest in wanting to know, what can I do as an individual to advance health equity? And I'm wondering if in the research that you've done to date, especially in a lot of the qualitative feedback that you've gotten from families, have they ever mentioned anything about what like an individual nurse or individual clinician can do to sort of help if that family is facing food insecurity?
I think yes. Yeah, thank you so much. So yeah, I think families, especially on the hospital-based food insecurity, I think the awareness, they appreciate if people are actually aware that they haven't eaten, and I think that is for me as a doctor is very important information, especially if I want to explain something complicated. So the awareness I think is important. We did ask families if they mind being asked the questions about having difficulties to afford food, or asking about difficulties to afford housing. That was done in the same study. I didn't present those. And about 80% of the caregivers on the general ward did not mind being asked those questions, which I also found very encouraging, because sometimes we clinicians find it difficult to ask these sensitive questions. So these are the things, I think, the awareness and asking the questions. It is difficult though, because it depends a little bit also in the setting you are. I work both in SICKITS, but also in the community. In SICKITS, I have more resources. I have a social work, I have resource navigation network. I can more easily refer, while in my community, there's no support. So I must say, I will not always ask in the community because I have nothing to offer. I find it hard to ask. I'm still struggling myself with that one. So yeah, it's food for thought.
Thank you so much.
Thanks, Harpreet. Opening up to other questions. Would anyone like to raise their hand? Okay, Julia and Dennis.
First, I just want to say incredible work, and the translation from your clinical questions, your research questions, right into practice is very inspirational, Meta and team. So way to go. My question is about moving forward. I think it's in your comment just about your community experience versus SICKITS is really important to this. Is how do we ensure as a hospital that we are not redundant in what we offer? So what I mean by that is, when do we take over everything as a hospital organization versus how do we actually enhance partnership with organizations that are already doing this work embedded within these individuals' home and communities, and therefore, as clinicians, increase our knowledge, awareness, and understanding about what else is available. It's so easy. I think it's easier when it's right there at your fingertips, but that's not always better. So I'd love to hear your thoughts on that.
Thank you, Julia. Yeah, you're absolutely right. This is also something we struggle with. That's why in this new working group, we collaborate with community organizations to see what we can do. I myself experienced, and maybe yourself too, when we refer to community organizations, patients do not always arrive. There is the issue of transport. And for example, with the tax now, I've been made aware through my collaborations with Prosper, Canada West Neighborhood House, there are way fewer tax clinics now because we were not the only ones struggling with the Uber driver. So because it's more common now, so there are fewer tax clinics, for example. I don't know. I don't have the answer to your question. I'm in the process asking first the caregivers. This was general peds. We're moving to the neonatal follow-up clinic to get a more different expertise, because I actually had the same doubts as you. Is this something that could be of value for SICKITS parents? And or should we have a better collaboration with these community organizations? So I can't tell yet. I'm in the middle of exploring, but it is definitely something we need to keep in mind, because creating all these new resources is will have a cost, and it's maybe not the best way to go. So hopefully maybe next year or the year after I can present on that. Sorry.
Okay, great. Thank you. So Dennis had his hand up next, and then after Dennis, there's also a question in the chat that we'll go to, followed by Eric. Dennis? Dennis, would you like to unmute yourself? Dennis, we can't hear you, and I'm not able to unmute you.
Oh, God.
Okay. Dennis, if there's a problem with the mic, could you maybe put your question in the chat, please?
you. Sorry.
Sorry about that. Well, if we go to the chat, Amimbola had a question regarding the health equity study. She asks, how do you currently track health equity or inequity? Are socio-demographic data presently collected for patients? And if so, what are the current methods?
So I come from a research perspective. So this is a research study designed for people who consent participating in this research. So I used validated questions and created one healthcare inequity questionnaire. We haven't used it yet, so I'm very pleased that we also collaborate with Samantha and here we do some qualitative work to see if these questions are actually the right questions to ask. Currently in the hospital, I don't think we ask these questions in a standard way. I know in EPIC there is screening questionnaire in the general pediatric ward. I know everybody has a different type of EPIC, and for those of you who don't work in sick kids, EPIC is our electronic medical record. So they are available, but to the best of my knowledge, they are not used standardly in each and every clinic. There are some clinics who are ahead, who have their own form and ask some of these social determinants of health. But to my knowledge, not in the inpatients, general pediatric, and in the ambulatory care, we don't use those questions standardly. And it's a big debate because, for example, the EPIC questions have been there since EPIC was live, but the people who ask it, they feel they need something to do. And currently, we don't have social work for every patient. I'm not sure if that's needed. We couldn't offer the meal cards for families. So I'm excited that with the pilot project offering the meal cards, we're going to go back to these questions and see if they're useful and we have something to offer. So sorry. Yeah. I hope this answers your question.
Okay. Dennis, you want to try unmuting your mic one more time? Okay. Eric.
Hey, if you can hear me, why don't you go ahead with Dennis's question in the chat so I don't jump the queue. It is in the chat.
It is in the chat. Okay. Thanks, Eric. Okay. So Dennis asked, do you have any information comparing the subjects in your studies to those using food banks on a regular basis? Secondly, have you costed out what the ideal program would be?
So no, I did not have any information about the use of food banks. We didn't ask. Frankly, the first study really surprised us, and yeah, we never asked. It was also in the middle of the COVID pandemic, so I wasn't sure. So no data. And then have you costed out what yeah, that is the big question. I really have no idea. So that is why we're doing this pilot study. And then we'll see, yeah, we'll collect metrics. So the first for the meal cards we'll do first. We'll collect metrics to see if we ask the questions. First of all, do we ask all the questions? If we ask everyone the questions, how many will say yes? Because there's a stigma there. And then they have to pick up the meal card in our family center because we can't have a stack of cards on the ward with monetary value. So they go there. So it will be a bit of a process. But yeah, and hopefully with that pilot, we know the number of admitted patients, we know my previous data, we can have a better estimation because that is what hospital management needs to know before we can roll this out on a more wards. And yeah, that's how we were able to get this additional funding to try it as a pilot because I have no idea. And especially now, because I think the last years, the inflation has only gone up. The food cost has only gone up. So maybe it's even worse. So yeah. Thank you. Important though, because hospitals do not have the funding and yeah, for this. Yeah.
Eric.
Thank you. Great talk, Meta. Really appreciate it. One group of stakeholders that I saw were not included in your studies yet would be policymakers. Like people from Canada Revenue Agency in the MFP type of project. One thing we find in IBD patients is their accountants say to apply for the disability tax credit, the federal disability tax credit, and 1 year they'll get it. The next year the policy changes somewhere that nobody knows about and they won't get it. And it's just very inconsistent as to who qualifies for what. So I'm wondering if you've engaged CRA or if you've engaged policymakers in fixing that problem so people know what to do.
Yeah, excellent. This is also my experience when working in a community with seeing children with developmental disabilities. You as a pediatrician, you have to write your head off, and then it's still a matter of chance. So I relate to your experiences. Through Prosper Canada, and they have some affiliation with the CRA, Allison Reserve. We've been that is our maybe indirect way to communicate with policy. I've also tried myself when the CVITP program was clearly not successful. I contacted the CFATP and I really got stuck. They were not interested in hearing anything from us. So I'm hoping through our network with Prosper Canada that we can reach, and that Jennifer Robson, the professor at Carleton University, she's also working on a higher policy level. She used to be at Prosper, and she informed us that CRA is even working on a tax system that for some families, if they have very easy, that the CRA does the tax for them. But this wouldn't help our population who have disabilities, who we have to file in these different forms. So this is a bit how far we've come. So if you have any suggestions, I will be open to it, or any connections.
I don't, but thank you.
Thank you, Eric. Anyone else? Okay, well, it looks, Meta, that is, the end of our talk. Do you have any further reflections to share based on the reactions you received so far? Anything more to add?
No, thank you. I really like this always because I think we all experience the same thing with a different population. So I really like the collaboration on tackling, addressing social determinants of health, including food insecurity in a hospital, but also in a community. So more work to follow.
Thank you. I think we're all looking forward to seeing the results of your study and your efforts. And just a final announcement to make before we all log off. Next week, we won't have a weekly round for CHESS because it will be our first business meeting for the quarter. And so, senior scientists and associate scientists will get an invite for that. And just a call to anyone who might want to present at a weekly round in the coming months to please let myself and/or Eyal know, or if you'd like to nominate an external speaker that you think would be interesting for the group to hear from, we'd love to get your suggestions. So please, let me and Eyal know about that. And otherwise, everyone enjoy your lunch. Thank you.